Okay. Okay. And is everybody able to see my screen? Okay,
Looks
great.
good.
So welcome everybody to the fourth Thyroid Awareness series. We started this about 4 years ago because there was a big interest among my patients to learn about the thyroid. And since January is Thyroid Awareness Month, we thought we should hold it in the month of January. We were hoping to do this one as a physical, but unfortunately, or in person, unfortunately, we're still dealing with the COVID pandemic. So we're so appreciative of Jeff's organizing this so that we can do a virtual conference. So my guest today will also be Dr. Rupen Shah. Previously, we've had several of our endocrine surgeons come in and teach us a little bit about thyroid surgery and what it all entails. Today, what I'm going to review is mostly underactive and overactive thyroid. That's mostly the questions that I get, but I'm open to any question you guys have. And I'll just get started with a brief anatomy. I'm sure Dr. Shah will go into more detail. So if we look at the thyroid anatomy, we know that the thyroid is a butterfly gland and in our neck. It has a right lobe and a left lobe and an interconnecting tissue that we call the isthmus. And how do we recommend that patients do their own self-thyroid checks? Traditionally, what I tell my patients is that they can have a glass of water ready and they need a mirror. And if they tip their head back just a little bit and drink, they'll be able to see the thyroid gland, which is just below the Adam's apple and above the collarbone. And they sometimes you will not see anything, and that means you don't have a goiter, you don't have an enlargement, you might just see something moving. And sometimes people actually detected thyroid nodules this way, and that's a good way to kind of practice and see what is going on. So to start with our topic, what I'm going to be talking about is an underactive thyroid. So that term for underactive thyroid is hypothyroidism. And this occurs when the thyroid gland produces less than the normal amount of thyroid hormone. What our patients will start noticing is the slowing down of many bodily functions. And this is very common. The most common thyroid disorder in the US is an underactive thyroid caused by a condition called Hashimoto'S thyroiditis, which is an autoimmune disorder. So what are our patients noting? Well, early on, probably not much. They may not initially notice anything, but you may get, part of it is because the thyroid is very good at compensating for an underactive thyroid. And slowly as things get worse, they may notice that the body's metabolism slows down and then symptoms can develop. So what are some of the symptoms? Excessive fatigue. Some of our patients feel drowsy or forgetful. For children, we'll see that they have difficulty with learning. Some folks would notice dry, brittle hair and nails or dry, itchy skin. Now, many of this overlaps. Like in the winter, we have dry, itchy skin and maybe a little bit of brittle hair, but this would be all year round. They can get constipation and sore muscles, weight gain and fluid retention. For our women population of reproductive age, you can get irregular menstrual flow. For women who have frequent miscarriages, gynecology and OBGYN are very good for checking for thyroid disorders. And we also see increased sensitivity to many medications. So what are the causes of hypothyroidism? There are multiple causes of hypothyroidism, and I'm going to talk about them briefly. One is Hashimoto's thyroiditis. Hashimoto's thyroiditis is autoimmune thyroiditis, and the body does not recognize the thyroid gland as a self and starts creating a destruction of the thyroid. Other causes may occur due to treatment that we give our patients. For instance, for patients who have an overactive thyroid, often one of the treatments we give is radioactive iodine. And about 6 to 8 weeks after the administration of radioactive iodine, an individual can develop an underactive thyroid, after which they're on thyroid pills for life. Another thing that we've been seeing much more recently and more frequently in our clinics is subacute thyroiditis. This is a painful thyroiditis. It's a painful inflammation of the thyroid. The cause is often not determined, but what we've been seeing with the COVID pandemic is we have been seeing post-COVID infection thyroiditis, and now even post-COVID vaccine thyroiditis. That is, some folks develop a very painful gland after the infection, or a few weeks to a month after the vaccine. And what this inflammation means is that they're leaking a large amount of thyroid from the cells that manufacture them into the bloodstream, and they can have symptoms of an overactive thyroid followed by symptoms of underactive thyroid. We can also have spontaneous onset. That is, you just have underproduction of the thyroid with no clear etiology. Thyroid surgery will be something Dr. Shah speaks of, and we can develop obviously an underactive thyroid. In this case, if the entire thyroid is removed, if a partial thyroid is removed, sometimes 40 to 60%, depending on the situation, 40 to 60% of people may develop an underactive thyroid. And then there's medications which can cause it. That is, lithium can cause it. High doses of iodine can lead to what we almost say as a constipation of the thyroid and can cause an underactive thyroid. Medications that we give to treat irregular heart rhythms like amiodarone can cause hypothyroidism. In our women of reproductive age and pregnancy, similar to the painful thyroiditis that we spoke of before, some of our women after delivery of babies develop postpartum thyroiditis. This is actually an inflammation of the thyroid that develops after pregnancy. They go through an episode of an overactive thyroid where they've released their stores into the bloodstream. And then because their thyroid is sick, it cannot, once the bloodstream clears the thyroid, because the thyroid is sick, it cannot manufacture new thyroid hormone just quickly. And so we see episodes of an underactive thyroid. The rule for this condition is actually complete recovery. That is, eventually the thyroid heals itself and we no longer have a thyroid disorder. And there's congenital conditions. Some infants are born with an inadequate amount of thyroid hormone, or they are not born with a thyroid gland itself. In the United States, every baby that is born in a hospital gets an immediate thyroid test. The reason that is done is because a treatment of an underactive thyroid is such an easy thing to do for a baby. We just give the baby thyroid hormone, while depriving a baby of thyroid is quite detrimental to their health. So as a standard screening test of every baby born in the US, thyroid is checked. And then very rare conditions that we saw some in the recent COVID pandemic is pituitary hypothyroidism. Some folks early on in March of 2020, when the illnesses were quite extensive, we saw there was destruction of the pituitary gland. And though in the pituitary gland, which is a gland that sits right between your eyes and the back of the head, this secretes a hormone called the thyroid stimulating hormone. And this hormone, if it is not properly released, you don't produce thyroid hormone from the thyroid gland. The treatment, again, is that you treat these folks with thyroid hormone and they do very well. So how do we diagnose an underactive thyroid? Well, of course, our patients will come in with symptoms. So we examine the patients and we ask as to their symptoms. And then there's laboratory testing that confirm the diagnosis. The most sensitive assay that we have is a test called TSH, which is the first and foremost test that we do, which tells us if there is sufficient amount of thyroid hormone in the bloodstream. Other tests which may give us a little bit more detail as to what kind of thyroid disorder is happening is a free T4. This is actually manufactured by the thyroid gland itself. And if necessary, we check for antibodies against the thyroid to see if there's an underlying autoimmune disorder. So what are the treatment options? The treatment options are quite simple. A single daily dose of thyroid hormone tablet is given to the individual. These thyroid pills are very simple and they look almost identical to the body as far as the molecule that was naturally made by the body. An experienced physician, your primary care physician most of the time, is experienced in titrating and knowing the appropriate dose and how to balance those doses based on the blood results. In our older population, we don't like to give too high of a dose. And part of the reason is that we have thyroid hormone receptors all over our body. We have it on our heart, we have it in bones, we have it everywhere. And in our older population, we like to ease into the thyroid hormone replacement so that we're not saturating the heart too quickly and causing irregular heart rhythms. In a younger population, we can just replace it based on what is missing all at one time because in general, the individual is quite healthy and we're not worried about any ill effects from the thyroid replacement. It takes quite a while for us to get the patient to feel better regarding symptoms. And that's something that I do ask my patients to be patient with. Once we start thyroid hormone, it may take months to notice improvement, for instance, in hair, cold intolerance, irregular menstrual cycles, etc. So though the levels within approximately 6 to 8 weeks look better, the benefit as far as symptoms go lag behind. The thyroid hormone replacement, if it's autoimmune, most likely will be a lifetime therapy. Once you have established dose, I see my patients once a year where we check the thyroid levels to make sure that the appropriate amount is in the body. Sometimes we do need to make adjustments as people's life changes. Some people go on birth control pills, which can affect the absorption, or have other medical conditions where they are put on medications or vitamins, which can affect the absorption of the thyroid pill. And under those circumstances, we might have to titrate the thyroid up or down. But again, it's a very simple way to figure out if an adjustment is needed by a simple blood test. The thyroid hormone tablets come in multiple forms. There's greater than 10 different strengths that we have, and we have multiple formulations. Some are name brand, such as Synthroid, Levoxyl, or Tirosint. The generic formulation is called levothyroxine. And then there's different preparations, which could be T4, T3 formulations, which are known as Armor, PWP, or Nature-Throid. So we have multiple options for our patients. If the dose of the thyroid hormone is too high for the body, we will notice changes where the patient might notice increased heart rate, insomnia, and it's not good for the body. We can also lead to irregular heartbeats or even osteoporosis. And if we have an underactive thyroid, that is, we're underdosing the body, this can lead to elevations in cholesterol, the patient feeling tired. And so we really do want to dose the individual to the proper level so that they're feeling well and not getting any ill effects. It's very important for our women of reproductive age who have thyroid disorders to have their thyroid labs adjusted before conception. We have a very narrow therapeutic window of where we want our women of reproductive age to have their thyroid labs be. The number, just for anybody who's interested, is to be less than 2.5. The reason we say that is it takes a while for a woman to know that she is pregnant. That is, she has to miss an entire menstrual cycle in order to know. And by that time, many organs of the baby have started to develop, and those organs need sufficient amount of thyroid hormone. If the mother does not have enough thyroid hormone for herself, she thus does not have enough thyroid hormone for her baby, and that could be detrimental to the developing fetus. So prior to pregnancy, we ask our women who are on thyroid hormone to have a planned pregnancy, to have their thyroid labs checked before they're interested in pregnancy. And often during their pregnancy, we need to increase their doses so that their baby has sufficient amount as the baby grows. And we keep on adjusting medications in the first, second, and third trimester. Again, thyroid hormone is critical for normal brain development in our babies, and that's why we're so meticulous in our pregnant population. So the next thing that I'm going to talk about is an overactive thyroid. So an overactive thyroid is having too much thyroid hormone. Every function of the body tends to speed up. These patients tend to be extremely uncomfortable. We see our patients feeling nervous. They almost tell us that they feel jittery inside their body. They have tremors to their hands. They have a racing heart rate. They have insomnia. They have anxiety. They have thinning of their skin and brittle hair, and unintentional weight loss despite a very good appetite. For women regarding their menstrual flow, they will lighten, or sometimes they won't have a menstrual cycle at all. The autoimmune disease that is most common to cause an overactive thyroid is called Graves' hyperthyroidism. In the patient who has Graves' hyperthyroidism, their thyroid might be quite enlarged, and it's enlarged in the right lobe, the left lobe, and in the middle lobe, the isthmus. We may see other signs of it, that is, patients may have eye disease associated with the overactivity called Graves' eye disease, and it's a bulging of the eyes where the eyelids are pulled back and it looks like the individual is staring. And they can have swelling of the front of their neck leading to what we call a goiter. This is an example of an individual who has Graves' disease with Graves' overactivity and Graves' hyperthyroidism. And what you see here is that the eyelids are back. And so traditionally, when we look at individuals, the top white of the eye is covered by the eyelid. But in this individual, it's pulled back and it appears as if the individual is staring at you. These folks also have a hard time sleeping at night because they can't always close their eyelids completely. And we worry about them getting ulcers in their eyes. So we have them sometimes they have been told in the past to tape their eyes closed to make sure dust particles do not come in. And we at Henry Ford have specific ophthalmologist that deals with Graves' eye disease so that they're able to get specialty care for their eye disorders. Other types of overactive thyroid include a toxic nodular goiter. This is characterized by multiple lumps or nodules in the thyroid that manufacture too much thyroid hormone. And also, as we spoke with the underactive, the thyroiditis, the inflammation of the thyroid, where the thyroid releases way too much thyroid hormone stores into the bloodstream. It could be due to an immune issue. It could be due to a viral infection like COVID. And because of the leaking of the thyroid hormone into the bloodstream, the individual becomes overactive. How is hyperthyroidism diagnosed? Usually by physical examination. We detect an enlarged thyroid. The patient will have a very rapid pulse and will note a tremor in their hands. Their reflexes are quite elevated and they can have bulging of their eyes. We confirm it by obtaining thyroid labs. In this case, this is where free T4 and free T3 are very helpful because they will give us an idea of how overactive the individual is. And then lastly is imaging. There's a nuclear medicine test called the thyroid uptake and scan. And this scan will find out if the entire thyroid is overactive, as we see in Graves' disease. Do we have just one nodule that's overactive and then only part of the thyroid is going to light up on these imaging? Or is it multiple thyroid nodules that are active? This is an example of what a nuclear medicine scan looks like. In panel A is a person without any thyroid disorders. Everybody will have a little bit of uptake, but it will not be enlarged, and normal in our system is below 30% uptake, depending on which nuclear study you look at. In Graves' disease, you could see that the right lobe and the left lobe are taking way more thyroid hormone, and that's because the entire gland is affected. In people who have multiple nodules, or we call this a toxic multinodular goiter, multiple nodules are overactive. And then in some folks, just one big nodule will be overactive, and this is considered a toxic adenoma. Whoops, I gotta go back here. Oops, sorry. Let me go back here. Sorry about that. Okay. So what are the treatments for an overactive thyroid? There are 3 treatment options that, depending on the condition, would benefit the individual. One is antithyroid drugs. In the United States, there's 2 approved medications. One is called PTU, and the other one is called methimazole. Radioactive iodine, which we briefly discussed, what it does is you give the individual radioactive iodine, and if you could imagine, it's like taking a grape and making them into a raisin, or the way I talk about it with my patients is that we actually kind of melt the thyroid away, after which an individual would be on thyroid hormone for life. And then surgery, which Dr. Shah would talk about for an overactive thyroid, is also an option. The decision of which one we use depends on the condition that the individual has, what is their particular goals, and what is safe at that time. So that concludes my talk. So I'm going to ask, we're going to hold off on questions, and I'm going to ask Dr. Shah I'm going to stop sharing slides to share his slides.
Thanks, Dr. Levy. And just a reminder, everybody, I see we have a few questions in the Q&A section. Thanks, everybody, for dropping those in there. And as Dr. Levy said, following Dr. Shah's talk, we will jump into those and walk through the questions. Thank you.
All right. Do you see my screen here?
Yep.
Excellent.
Yep.
Okay. All right. Good afternoon, everybody. And thank you for calling in this Friday afternoon. So I'm a surgical oncologist and an endocrine surgeon here with Henry Ford Health System. I'm just going to go over a little bit about thyroid surgery, what to expect, how we prepare for thyroid surgery, recovery after thyroid surgery, and also potential complications, and what we are doing as surgeons with regards to newer technology and how to decrease the chance of some of these complications. So the first thing is, I think Dr. Levy has gone through all of this at great length, and thank you so much for that very comprehensive overview, Dr. Levy. I will focus on some of the reasons why a surgeon would be involved. One of the things I would like to highlight is having a good team of an endocrinologist and an endocrine surgeon. Having that comprehensive multidisciplinary team looking after you with regards to endocrine disorders and especially thyroid diseases is very important. So thyroidectomy, when we use that term, what we mean is surgical removal of all or part of the thyroid gland. So when do we recommend it? So as Dr. Levy was mentioning, some of the indications for surgery could be non-cancerous enlargement of the thyroid, which we call a goiter. And a goiter can be diffuse where the entire gland is enlarged, or it can be multinodular where there are multiple enlarged nodules leading to the enlargement. And typically in these patients, we see a couple of reasons for surgery. More often than not, it is for compressive symptoms or symptoms when they are swallowing, they feel like there's something stuck in their throat. When they start developing a hoarseness of voice, or it's starting to press on the windpipe or the trachea. That tends to be the typical reasons for a surgeon like myself to see patients when they develop enlargement of the thyroid gland. Of course, for cancer of the thyroid, and there are different types of thyroid cancers for which surgery is indicated. And overactive thyroid, as Dr. Levy was mentioning, could be from thyroiditis, but that is typically not an indication for surgery. Graves' disease, however, tends to be a very good indication for surgery in the appropriate patient. And this is where working closely with my endocrinology colleagues is important for me, because they help me prepare this patient to get them to surgery safely. These patients tend to have, as Dr. Levy was mentioning, a lot of cardiovascular effects, in the sense that all of their bodily functions are elevated, especially the ones with the heart is what we worry about in preparation for surgery. And then in some instances, when we have patients with indeterminate or suspicious nodules. So what do I mean by that? Typically when we have, or when endocrinologists or a primary care doctor is evaluating somebody with a thyroid nodule and they obtain an ultrasound, the first step when they meet criteria for a biopsy, we do a fine needle aspiration biopsy. So a small needle is used as thin bore needle, and some cells are obtained under guidance with ultrasound. So they're looking at this nodule under ultrasound guidance and obtain some cells, and we take a look at it under the microscope. And that helps us determine whether this is a cancerous, benign, or then sometimes we have this gray area where they are indeterminate or suspicious. And more often than not, we have more testing that we can do on it. But sometimes, despite all of the tests, we may have to resort to surgery to remove part of the thyroid gland to get a better idea of what this thyroid nodule may be. So how much of the thyroid gland is removed for surgery? So it could be what we call a hemithyroidectomy or lobectomy, where we remove half of one half of the thyroid gland, or it would be a total thyroidectomy where we remove the complete thyroid gland. And the indications for each of these depends on what we are doing it for, and also certain patient characteristics. So what can you expect during surgery? So typically, this does not require a whole lot of preoperative preparation, apart from you come fasting the day prior to surgery. If there are certain medications like blood thinners, we would instruct you to stop those before surgery. In addition to that, if there are thyroid medications that you are on, we would instruct you whether you need to stop them, take them on the day of surgery, what needs to be done. And especially in those patients with the overactive thyroid, we do make sure that their heart rate is well controlled in patients with Graves' disease, etc. So all of those things are very important in preparation and to make sure that we can optimize and safely perform your thyroid surgery. So the procedure is done under general anesthesia, so you will not be conscious during surgery. After general anesthesia is induced, then the patient is placed in the appropriate position. We want a little extension of the neck for appropriate exposure. Then we place monitors so that their heart rate, blood pressure, respiration, everything is appropriately monitored. And then the use of nerve monitor. So this is very important in thyroid and parathyroid surgery, where there is a very important nerve to the vocal cords of the voice box called the recurrent laryngeal nerve. So there's one on each side. So depending on if you're having one half of the thyroid removed or we're taking out the entire thyroid, both of those nerves may be at risk based on the surgery we are doing. And a nerve monitor, and I will be showing you some pictures of that in a minute here, is an important instrument and adjunct which helps us identify and protect it. After this, I'm going to show you some pictures of intraoperative surgery. So here is a patient where we have marked out the incision, and this patient had a single nodule on the thyroid gland. After we open the skin and we get through the first layer right underneath the skin, which has some fat and blood vessels. We get to the muscle layer. So here you can see that we have retracted the flap. So that's the upper portion. This is the lower portion where the skin and fat is retracted out of the way, and we get right on the muscle. And then we split the muscle. We typically do not cut the muscle unless it's a very large thyroid gland. Unless it is very large and we don't have a good visualization that we're not able to see the important structures, we just split it. So we split it right in the middle. So after we've done that, so we are now, you can see this is the thyroid gland. So we're right on that nodule that we had marked out. So we're right on that thyroid gland now. The thyroid gland is a very vascular organ. So it has a rich blood supply. And one of the risks with this surgery is bleeding. So we take a lot of care. We use advanced sealing devices with blood vessels. We use sutures, clips, etc. And once we have secured the blood supply to the thyroid gland and identified, as I was mentioning to you earlier, so here you can see what we have done is, this is the right side. We have moved the gland out of the way. So we've retracted it. This is the airway or the windpipe or the trachea. And right here, you can see the structure here, and that is the nerve, the recurrent laryngeal nerve that supplies the vocal cord. And here is one of those parathyroid glands that I was talking to you about. And I'll go into a little bit of details about importance of these structures and how and what we do as surgeons to help identify and protect them. So once we have identified these structures, we then take the rest of the gland off the operative field from the trachea and divide it. And this is one of my other patients. So this is where they had a large nodule here. This was actually a patient with cancer in this and had a strong family history. So that's why we decided to take the entire. So this is entire thyroid. So this is the left lobe of the thyroid, this is the right, and this is what we call the pyramidal lobe. So this is what we would end with as an end result. So when we are So when we're thinking about the partial or taking part of it and the total, right? So we have several things that go into making that decision. The size of the nodule, whether we're doing it for cancer, even for small cancers, you don't routinely have to have your entire thyroid gland removed. So, and that is something that I work closely with my colleagues, endocrinologists, who help me with that decision-making and patient preference. Then we're looking at if they have thyroid nodules on the other side, if they have a high-risk thyroid cancer, if they have a family history of thyroid cancer, if they have received radiation in the past for whatever reason. Those are the patients where we would be more worried about. So why are we, the general tendency is, oh, I have a cancer, I just want my whole thyroid gland out. That's not to be taken lightly for the reasons that I just mentioned, is the risk for injury to both of the nerves and risk for low calciums if all the parathyroid glands are injured and none of them are preserved. So the removal of the entire thyroid gland can put you at risk for injury to both of the nerves and for low calcium. So after surgery, typically, if we are taking out only one side of the thyroid gland, does not always require an overnight stay or admission in the hospital. Patients can leave in a few hours after surgery as long as their pain is well controlled, they're able to swallow comfortably and don't require any IV pain medications, and their calcium levels are normal, etc. Drains, we don't routinely place drains after thyroid surgery. The only times I've needed or placed a drain is, remember I told you the thyroid gland has a very rich blood supply, and where we are at risk for bleeding and I'm concerned that the blood collects in that area, it may cause some problems with breathing after surgery. Only in those instances do we place a drain. Otherwise, we do not routinely place drains after thyroid surgery. With regards to diet, typically the evening of surgery, depending on how much we had to do, we may start patients on some ice chips and some liquids, and the next morning they're given a regular diet so they can have breakfast. A lot of patients do have some soreness and hoarseness that they complain of from the breathing tube going in. And also we are stimulating the nerve. So that does cause a lot of hoarseness and some pain. So they're not going to eat their entire tray, but most patients go home on a regular diet. With regards to care of the incision, not a whole lot, to be honest with you, because we use all absorbable or dissolving stitches on the inside, and we place this bioabsorbable glue on top. It's called Dermabond. And patients can start showers within 24 to 48 hours after surgery. I do not recommend baths where they're soaking the incision, because we don't want that, at least for the first 10 days to 14 days, but showers after 24 hours are absolutely okay. The other thing I do tell my patients is to avoid hyperextension. So those who are in like yoga and Pilates, I tell them to avoid that, because I don't want separation of that incision as the scar is developing, and to get a nice clean scar there. Pain after surgery, typically thyroid surgery is very well tolerated. Pain again is very subjective, so it's hard. Everyone's pain threshold's a little different. I send most of my patients home with no more than 5 to 10 of the stronger opioid pain medications. I have had patients who some of whom say, I'm fine, I don't even need that. I have not had any patient actually call me back for a refill. I actually have some of these patients come back and return their, even when I send them home with 5 of the Norco pills, the hydrocodone, they return it to the pharmacy. So overall, very well tolerated. Tylenol and Motrin works just fine with thyroid surgery. But again, like I mentioned, it is very subjective with pain. There are some patients who are opioid dependent or have been taking pain medications for other reasons who may require a little more than usual. And activities, like I was mentioning, apart from the hyperextension of the neck and strenuous activities, routine activities of daily living, like walking, showering, going to the grocery store, up and down the stairs, walking, all of that is encouraged. Don't see any reason for them not to return to normal activities. And all of my patients, of course, they follow with me for a follow-up appointment where we evaluate the scar. If we have done a total thyroidectomy, that is removing the entire thyroid gland, then we check their calcium levels, also assess their voice. If there is any hoarseness, is that, what does that mean? Has it improved? Is it better than before? Generally, I ask a family member who's with them. They are a very good judge of, how do they sound? And they're typically able to tell us, well, this is not how they sound, or, it was a little raspy at the beginning and now they sound fine. So they tend to be a good judge of that as well. And of course, we discuss the results of anytime we take out part of the thyroid or the entire thyroid gland, we send it off to testing, and our pathology colleagues go over that and then return those results to us. And we discuss that with the patient. If there's we were doing it for cancer, or if there was a surprise cancer when we weren't doing it, what do we need to do as next step? So we go over that. I do start patients on the standard dose of levothyroxine or the thyroid hormone replacement when we take the entire thyroid gland out. And then they follow with my endocrinology colleagues for titration of that dose. So some of the risks, right? So I was talking, as I had mentioned, bleeding, typically not to the point where we would require blood transfusion, but as I had mentioned, the thyroid gland is a very vascular gland, and this is something that we always worry about. So we keep a close eye, especially if you're taking the entire thyroid gland. Most patients stay overnight, and the most important thing we are watching for is bleeding after removal of the thyroid gland. That does happen. That would be one of the reasons to go back to, remove that blood clot from there and find the area that was bleeding and take care of it or fix it. The voice changes. This, hoarseness, we do see in about 30 to 40% of patients. remember that it does not always mean that the nerve was injured. Hoarseness can be just from the breathing tube going in there, and that can cause irritation and hoarseness. It could mean because we were doing dissection on the nerve and reflecting the thyroid that it was stretch on the nerve. It doesn't always mean it was cut in half and completely injured. So hoarseness is something that we look at very closely. And if it is getting worse, or it's not improving, then we test that further by looking at the vocal cords and decide on what needs to be done. The risk for the nerve to be injured permanently is less than 1%. So one of the key things, and I'll talk a little more about how being meticulous at the time of surgery, we as endocrine surgeons, we use magnifying loops. So I wear 2.5 times magnification loops at the time of thyroid and parathyroid surgery, because we have found that using magnification actually decreases your risk for nerve injury because it helps in identifying it and protecting and keeping it out of the way. And number two is finding those small parathyroid glands and preserving its blood supply. And that's where this low calcium comes into play. So there is a really nice app, and this is a free app. It's called the Thyroid Navigator App. In all disclosure, I don't have any financial connections with this company or anything like that. I use this to show my patients what a thyroid surgery and what it may mean. So I'm going to play a little bit of animation here. So this is, as you can see, this is the thyroid gland here. This is the outline of the thyroid gland, the butterfly-shaped gland we talked about. This is the tracheal cartilage, and that's the windpipe or the trachea right behind it. So the thyroid gland envelopes or is surrounding this trachea. The red and blue are the blood vessels that are providing blood supply to the thyroid gland. So for instance, I have marked out here that this patient has a nodule here on the left side of the thyroid gland, okay? So I'm going to play this little clip, and this is something that I can do on my phone where I zoom in, and then, so here is the blood supply to the thyroid gland. And now if you look on the back side, and I'm going to pause this animation, these 4 small green colored structures that you're seeing that they're marked, those are the parathyroid glands. They're small, split pea-sized glands that we see behind the thyroid gland. As you can see, they share their blood supply with the thyroid gland. So the blood vessels that supply the part of the thyroid gland also provide blood supply to these parathyroid glands. In addition to that, you see these green lines here. These are the recurrent laryngeal nerves, one on each side. As you can see, it is very intimately involved with the thyroid gland. And especially when we are doing thyroid surgery for cancer, we have to make sure we are not leaving any thyroid tissue behind. So we want to take out all of that thyroid tissue that's even close to the nerve. And if we have that cancer very closely associated with the nerve, those are the nerves that are at high risk. So when there is injury to the blood supply to these parathyroid glands, then that's when we end up with low calcium levels. So if you were to ask me, how often do you see low calcium levels? Again, it can be temporary for the first few weeks after surgery. That's because they may have gone into shock because of the dissection and the blood supply was temporarily suspended to it, and then it goes back. Sometimes I've done this where in about 10% of patients, when during dissection, one of the parathyroid glands loses its blood supply, I can tell because it starts looking a little purple to black, and I know the blood supply is compromised. I immediately implant it. So I put it back in one of the muscles in the neck, and then the blood supply from that muscle brings these glands back. So it's called reimplantation. And that helps. Over time, it takes about 8 weeks up to 12 weeks for those glands to come back to life. And once they do, then patients' calcium levels go back to normal. Until then, we supplement them or support them with calcium and vitamin D. Initially, we have to start off with larger doses, and then we can start tapering them down. So this is where finding these small glands and protecting these nerves is key to thyroid surgery, and using appropriate magnification. Also, when having thyroid surgery done by somebody who does this, enough of these is important, not somebody who's doing one a year, especially, and that has been shown in several studies. This is not my personal bias or anything like that, in several studies to have the best outcomes. So what's new with thyroid surgery? Nerve monitoring is not really new, in all honesty. This has been around for decades, but now is almost standard of care. So what we do is, this is part of the breathing tube that goes down when the anesthesiologist is putting you under general anesthesia. Now, these special tubes have electrodes here. So they sit right, so this is the vocal cords, and this tube sits right next to the vocal cords, and they are connected to a monitor. Then at the time of surgery, we use a probe, which is a thin pencil tip. It's a long black probe. And then when I identify the nerve and I want to confirm, I use this probe, place it right on the nerve, and I get a return signal. So I know that I'm right on the nerve. I then have visualized it, I've confirmed it, I know it's working. So then I dissect away from it. And at the end of removal of the thyroid gland, whether we're doing one side or both, or total thyroidectomy, we confirm that the nerve is working on both sides. Because after that, and when I know the signal is intact and the nerve is working, even if the patient has some hoarseness, I am confident that it's not from injury of the nerve, it's probably from stretch, or it's from irritation from the tube. So this is a very important device, and it has really changed how we look at thyroid surgery. In the past, it used to be old school teaching that if you don't see the nerve, you won't injure it. Now the American Thyroid Association and all the endocrine surgery groups have recommended that you should look for the nerve and help identify it and protect it. And that's the best way to do thyroid surgery. And the second thing that we are looking at more often, I have used this on 5 of my cases. I know one of my colleagues uses it more often. This is now FDA approved. So what we are doing, apart from nerve, right? Remember, the other thing is low calcium, or the permanent low parathyroid hormone levels because of injury to the parathyroid. So how do we do better at this? How do we identify them? Because they are so small, sometimes you can't tell the difference between a lymph node and parathyroid tissue, or surrounding fat and parathyroid tissue. So now we have devices that utilize the knowledge that parathyroid tissue has its own autofluorescence. So we are able to place, so the one that I have used is this PTI. So both of these devices are FDA approved. Again, I don't have any association with either of these companies or any financial relationship with them. Using this probe, if we place it right on that parathyroid tissue, you're able to identify, it gives us a return signal. Yes, this is parathyroid tissue, or no, it's not. These are not perfect. They're adjuncts to normal anatomical landmarks that we use, that we've learned over time. But they have helped decrease that risk for permanent low PTH or low calcium levels. So I think we are moving in the right direction to improve outcomes with thyroid surgery. But I would recommend and encourage you to talk to your primary care doctor, your endocrinologist, because they are your best resources for who your right endocrine surgeon and endocrinologist should be. And it is a team effort that leads to successful outcomes for thyroid diseases. I lean on my endocrinologists a lot. They do this every day. They know the ins and outs with all the differences and the changes in the hormone levels, making sure that they are optimized for thyroid surgery. And that's what makes thyroid surgery successful, is making sure you have a good team. Thank you again for calling in today, and be happy to take any questions.
All right, thank you, Dr. Shah. We're going to hop into the questions, everybody. We've got quite a few here, so hopefully we can get through as many as possible. Some of these might be a little too specific. It might be best addressed by your physician, but let's go ahead and see how many we can get through. So the first one here, I'm going to go in order. Are there any precautions one should take when getting dental x-rays? Will x-rays affect the thyroid gland?
So that's a very good question. And as when we're talking, just like Dr. Shah said, when I see a patient with thyroid nodularity, I have three questions that I always ask. Do you have any swallowing difficulties? Do you have any voice changes? And have you ever had radiation to your head or neck? Nowadays, with x-rays, or at least when I go to the dentist, they always put that lead thing on your neck. And that's because of years of history where we were not doing that. And that was x-ray exposure to the thyroid. So the answer is yes. The standard of care for dentists is to protect the thyroid. There is a special lead little heavy thing that they put on it when they do your dental x-rays. But I can tell you that years ago, we did not do that. Years ago, we used to go to the shoe store and they used to have those screens where you used to step on them and you could see the bones in your feet that had radiation exposure. All of these things have been abandoned. I mean, as a kid, I used to play with mercury. My kids are not playing with mercury. So yes, wear a lead shield over your thyroid when doing x-rays.
Thanks so much. Moving on to the next one here. Is there an alternative to surgery for nodules? Any natural way to trying to bring the thyroid back to normal?
So, actually, and I'm going to ask Dr. Shah if he's doing it. I know that his colleagues or surgery, there is it's like a radio frequency. Is that
Yeah,
it?
that's exactly
Maybe you
right.
can speak about that. Yeah.
Yeah, so there is, and right now there's still data that's being developed with regards to size of the nodule. So what we do is basically ablate it with radio frequency. So a probe, just like you would get a needle biopsy, similarly you would numb the skin and under ultrasound guidance place a probe right in the middle of the nodule and then burn it. Essentially, it's burning it, it's ablation. And there are certain limitations to how close is it to the nerve, how close is it to the blood vessel, the carotid artery, and also the size, because you can't have a very large nodule. Right now, it is not approved by insurance. Is the last when I spoke to our colleague, why am I blanking on her name, down at Henry Ford LiveWell, who does it. I apologize. If it comes back to me, I'll make sure I chime in her name. And but it is being done. There are patients, especially patients who are high risk for surgery. For instance, they are in their 80s or 70s and have a lot of medical problems and cannot safely undergo anesthesia and surgery. That's when the radiofrequency ablation of thyroid nodules is tried.
Yeah.
All right, thank you. Moving on, a recent ultrasound showed changes in the R2 nodule. Once fluid, it is now solid. It is wider than tall and has calcification. Triads 4, margin, shape, Smith. It meets the criteria for an FNA. It has been difficult to get an appointment. Are either of you accepting new patients? Fatigue has been bad as well as loss of hair, shortness of breath, and hoarseness.
So it sounds like the individual is sharing with us the ultrasound TIRADS. So when we're looking at ultrasounds, there's a TIRADS that we use. We talk about it's basically characteristics. Is the nodule, does it have a nice circle around it, or does it have fingers? We call that lobulation. Does it have microcalcification? Does it have increased vascular flow? Is it growing taller than wider or wider than taller? Is it darker or lighter, called hypoechoic? So it looks like the particular nodule changed characteristic from purely cystic to a solid. And they are concerned and have labeled this TIRADS 4. TIRADS 4 nodules, depending on their size, sometimes meet criteria for biopsy. And yes, we are accepting new patients. If you do not, this is more for the endocrinologist, because we would be the ones doing the biopsy if needed. At Henry Ford, we do biopsy with molecular genetics on every single one of our patients. We just don't do biopsies. That is, we also send for molecular genetics that if the nodule is read as indeterminate, we can look for genes that could be suspicious, which might give us more information of whether this needs surgery or not. Yes, Henry Ford Endocrinology is taking new patients. Outside of me, there are a total of 9 endocrinologists who are excellent trained, and I will advocate for every single one of them. So if you can get in with any one of us, I would take the appointment. There may be a little bit of a wait, but yes, we are all taking new patients.
Yep, thank you. And anybody interested in requesting an appointment can do so on henryford.com. Okay, moving on to our next one here. If you have Graves' disease but no eye issues like bulging, so it looks like this individual had radioactive iodine treatment, can you still develop eye issues if your thyroid levels are being well managed?
Very good question. The answer is yes. Okay, so traditionally, thyroid disorder and thyroid eye disease go together. It's like a bell-shaped curve. They go together. On occasion, my colleague, Dr. Hunsegay, had one not too long ago. The person developed severe eye disease, and it was Graves' eye disease with normal thyroid labs. The thyroid labs became abnormal months and months later. And occasionally we'll have patients who have been treated with radioactive iodine. And we had a patient in her 80s who developed Graves' eye disease years and years after the original diagnosis. So though exceedingly rare, on an occasion, we do see it.
All right, thank you. If you are on small dose of Synthroid, how often are you supposed to get checked, and can your primary doctor take care of the treatment plan?
Very good question. The answer is the primary care physicians in general are probably your best advocate, and they are doing the majority of thyroid disorders in the community. They are seeing the majority of it because thyroid disorders are quite common, and titration of thyroid hormone it can be done by an internist who's trained in this. So the answer is absolutely. Our internists have been doing an excellent job. Our primary care physicians have been doing an excellent job, and they do a great job referring out when they have difficulties with titration.
Excellent, thank you. Question here. I've had radioiodine treatment in the early 90s. My thyroid goes hyper off and on. I'm dealing with that again for at least a year. I'm seeing Dr. Levy next week, but I don't understand why this keeps happening when the gland was destroyed.
Okay, so we'll probably talk about it at the visit next week, but sometimes it doesn't destroy the complete thyroid tissue. And if there's remnant thyroid tissue that is still quote unquote alive, it's not a raisin that went to a grape, but a partial, I mean, like it's not a grape that went to a raisin, but there's a little bit of grape there. It's a little bit juicy still. It could still make thyroid hormone. So we'll investigate when I see you.
Perfect, thank you. Another one here. I have Graves' disease and minimal TED. I'm having cataract / astigmatism surgery on Monday. My concern is the symptoms of TED, the constant fluid in my eyes, and I have I'm probably gonna say this wrong, Brudah, BRUDAH mask, and use Soothe XP drops. Go ahead.
So what I would tell you is we are very, very fortunate. Very fortunate. At Henry Ford, we have 2 Graves ophthalmologists. That is, these are folks who are trained in Graves' eye disease. One is Swapna Vemuri, and the other is Christian George. If you have any concern that TED is thyroid eye disease, for those who didn't know the acronym, if you feel that you are experiencing thyroid eye disease and wanted an expert opinion, I do refer to those 2 folks quite a bit, and they're excellent.
That was Swapna Vemuri, and the other one again, Dr. Levy?
Dr. Christian George and Dr. Swapna Vemuri.
Got it. Okay, thank you. What if you show symptoms of a thyroid disease, but the blood tests are in the normal range?
So, thyroid disorders, that's a very good question because we get that quite a bit. Thyroid disorders overlap with many other conditions. So if your doctor has tested you for thyroid function studies and they came back normal, it does not mean that you don't have an underlying something else. I think those symptoms have to be investigated because there's, there's multiple other autoimmune conditions, lupus, et cetera, that can mimic many of the thyroid disorders. And so maybe further investigation have to occur. But the thyroid labs are so good and so sensitive that if at the time that they're normal, that should be very reassuring that your thyroid function at least has been appropriately evaluated and has been ruled out as the cause of the symptoms.
All right, thank you. I have hypothyroidism and do have 2 nodules on my thyroid that my doctor is monitoring. Are there any foods or changes in my lifestyle that may help reduce the amount of medication I have to take every day or slow down the growth? Also, once on medication, will I be on medication for life?
I'm gonna have Dr. Shah just speak to this for a minute, but I could tell you this. When I started my training, it was around just 10 years prior to that, they stopped using thyroid hormone to shrink nodules. There was a practice that to shrink benign nodules, we used to give an individual thyroid hormone, and they had success with it. I mean, some nodules absolutely did shrink. The problem is the amount of irregular heart rhythms and cardiovascular bad effects that were occurring from this was not justifiable. That got abandoned. And on a very rare occasion, do we nowadays start people to shrink thyroid nodules for symptomatic relief. Nowadays, what I would tell you is I don't see that very often. It stopped. It was a practice that was probably stopped in the 1980s, late 1990s. If there's thyroid nodularity that we think is causing compressing symptoms, etc., we would send you to Dr. Shah for an evaluation, at which time he will discuss options.
I agree, Dr. Levy. I think that has gone away. It used to be done in the past. And I think also in a lot of iodine deficient areas, especially because of that relationship with benign nodules. But if there are symptoms from compression, I think surgery is the best treatment there. I would caution though, I have seen this very often where patients present with hoarseness or this globus sensation, something stuck. A lot of them have reflux problems with vocal cord injury and damage. So I do have, if this is a small, like it's not a 5-6 centimeter or large gland, it's a 1 centimeter nodule. Generally, a 1 centimeter nodule does not cause compressive symptoms. It has to be a sizable nodule, and there's probably something else going on. I've picked up vocal cord polyps. I've picked up damage to vocal cords from reflux, etc. So I reach out to my speech and language pathology folks and also my ENT colleagues for this, and they do a thorough evaluation before so that there are expectations set, right? Like if I take somebody to surgery, take out their thyroid and they still have the same symptoms, I haven't really helped them.
All right, thank you. Moving on to our next question. Should iodine and the other hormones be tested along with the TSH? Does iodine have an effect on thyroid?
Yeah, so iodine is the building blocks of thyroid. So when we say the words, some of the T4, T3, that is how many iodine molecules are in there. And when we say we deiodinate, that means that one of the iodines is being removed. In the United States, to be iodine deficient is exceedingly rare. In general, we recommend about 140 micrograms of iodine per day, which you are getting. I can tell you're getting, at least in Metro Detroit in this area. Part of the reason is that the farmers in the US are using soil that is iodinated, growing your fruits and vegetables in iodinated. And not only that, iodine is supplemented in our breads and everything. To see the iodine goiters, you have to go to like remote areas in Italy and etc. in order to see that. Very rarely do we see it in the metropolitan areas of, actually, I wouldn't even say remotely. We just don't see it in the areas that are metropolitan, like Metro Detroit.
All right, thank you. Moving on, so several years ago, the Mayo Clinic recommended that for older persons, TSH levels of less than 10 would not require use of, I'm going to say it wrong, you probably know what I'm talking about.
Levothyroxine, yeah.
Yes. Do you have a comment on that?
Yes, thank you, Mayo Clinic. So I just gave a lecture on this. So at Henry Ford, our reference range was a TSH, I think, of 0.35 to 5 was the normal reference range for what I call octogenarian, our 80 years old. I worked with Ben Cook, who is our lab, and based on the NHANES 3 data, we have now changed the reference range to be above 7.5 for our older population. And that is a new thing for Henry Ford. Part of the reason is, and we used some of it from the Mayo Clinic data, as an individual ages, there may be a protective effect of the TSH rising. And we may not want to start the elderly on thyroid hormone because, again, we're stimulating their heart and et cetera. And it may be fine for the metabolism to slow down a little bit. So the answer is for our octogenarian or elderly population, even at Henry Ford now, we have changed the reference range to reflect a more appropriate range.
All right, thank you much. Let's see, what's our next one here? Can you speak to the most beneficial thyroid replacement medication to treat Hashimoto's? I've been on generic levothyroxine since 2009 and continue to have symptoms. My dosage has kept my TSH mostly under 2 with occasional fluctuations above 2. Is it common to have sensitivities to ingredients in generic med forms in patients with autoimmune thyroiditis?
Very good questions. That's a common question I get. Do I have a preparation that I like better than other? No. I can tell you in general that the name brands, for instance, if you take name brand Synthroid, name brand Levoxyl, name brand Tirosint, you're always going to get the exact same medication every time. The problem is it's not very cost effective for many of our patients whose insurance companies will only cover generic preparation. So what I advise my patients is if they are taking a generic preparation, like let's say levothyroxine, that they always speak with their pharmacist to get the same generic preparation. What happens is the pharmacy in general will contract the cheapest brand that they have a contract with, which may be preparation A, and then 6 months later, maybe preparation Z. But for a patient who always gets preparation levothyroxine Mylan brand, where they go to Costco and its Mylan brand, they go to Walgreens and its Mylan brand, they should have less fluctuations and they should be able to feel better on the fact that they're on consistent medication. The question of, are there sensitivities? Tirosint, which is the purest form of thyroid hormone, is a preparation for people who feel that the fillers within the thyroid preparation may be causing them symptoms. That is, some people have celiac disease, they have gluten issues, and there are some preparations which may have some of those components. If they want the purest form, to date, from what we have, is the Tirosint brand thyroid hormone.
Okay, thank you. Moving on, I had Graves' disease in my late 20s, had radioactive iodine, been on Synthroid, or currently levothyroxine, 125 mcg, I'm 63. For about 15 years, I feel as if I have a lump in my throat 100% of the time. Have had endoscopy 3 times over the years, and all negative. No thyroid nodules. My question, can my thyroid gland, since never removed, be causing the feeling of a lump in my throat? This has not affected my eating. It is more of a nuisance, not knowing what it is.
Okay, so it sounds like this individual got, radioactive iodine years ago?
Yeah. Yes.
Then I'm going to talk to Dr. Shah because to tell you the truth, lump in the throat is something we see, but usually refer to for evaluation. So Dr. Shah?
Yeah, so, I generally, the time that I've seen when somebody has a very small gland that is causing problems is with Hashimoto's more so than Graves, who's received radioactive iodine. What happens with radioactive iodine is the gland becomes very atrophic, but doesn't cause a whole lot of scarring or fibrosis. Sometimes it can. What I would recommend is, apart from the endoscopy, that this lump in the throat sensation is what they do, a swallowing test where they make you drink some contrast and take serial x-rays and actually see how your swallowing is and whether there is any changes with the musculature, the muscles of the throat that help with swallowing. Is that the reason and not truly a gland? If your ultrasound shows that your gland is normal in size, or it should not be normal, it would actually be very small. If somebody has received radioactive iodine in the past, typically should not be causing you symptoms. So there's probably something else, especially with Graves.
All right, thank you. Next one. I've had total removal surgery 10 years ago. Blood work normally looks good, but I'm still always tired, losing hair, and gaining weight. Any suggestions or special tests / remedies available?
So because the TSH, which is our thyroid screen, is so sensitive, if the individual is noted and the labs come back normal, I really don't necessarily say that it's the thyroid that is the cause. There may be some other issues that have to be investigated.
All right, thank you. A small nodule was detected on my right side of thyroid through a CAT scan following a car accident. I had a fine needle aspiration done a year ago. Recently, it was determined my nodule increased slightly in size from another ultrasound. Should I be concerned?
So we have criteria for that. It depends on what the increase means. An increase in size in and of itself is not concerning. We are looking for a 20% increase in characteristics that are concerning. So the radiologist will always let us know the volume increase during at least at Henry Ford. I know that we have asked radiology and they've been very thorough. They will give us a volume percent increase, and they will also give us characteristics. So based on characteristics and percentage increase, then we would be able to comment. But a small increase without a change in characteristics does not always appear to be worrisome.
All right, thank you. What is the cause of low calcium with Hashimoto's?
So Hashimoto's should not cause low calcium unless we have, Hashimoto's is a autoimmune disease that is causing destruction of the thyroid gland. Per se, the parathyroid, which is what Dr. Shah was talking about, should be protected from that autoimmune effect. There are rare conditions which can cause low calcium, but I wouldn't necessarily say that Hashimoto's is the cause of the low calcium unless the individual underwent surgery and there was parathyroid vascular injury or the parathyroids were removed.
All right, thank you. Let's see here. For surgery, can you just take the nodules out?
I'll take this, so that's okay with you, Dr.
Yeah, of course.
No, typically not. So unless the nodule is involving the whole one lobe of it, then we just take that lobe, again, based on what the results from the biopsy is. The thyroid gland is so vascular that taking part of it, just taking part of the nodule and removing it, that entire area is just going to bleed the whole time. So no, typically not just taking the nodules out. You have to take at least 1/2 of it out. If it is on the isthmus, which is the middle of the thyroid gland, like where the two sides meet, sometimes I've done that where we do what we call isthmectomy, or just taking out the isthmus and leaving the two sides normal. But we don't just remove a nodule.
Okay. My doctor told me that hypothyroidism can affect absorption of vitamin B12. Are there other vitamins or nutrients that might also be affected in terms of absorption?
So that's a good point. I'm not sure why particularly B12, but I could tell you this. When an individual is underactive, that is, they have hypothyroidism, they can develop gut edema. That is like you get swelling in the gut. And then the absorptions of vitamins in general can be affected. So the answer is you really have to treat the thyroid properly so that the absorption of all vitamins and nutrients are absorbed through the gut properly.
All right, thank you. Let's see, next one here. Is there a lag time between a need for thyroid replacement and an elevated TSH?
Yes, there is. So it takes, many of our patients want to see the TSH normalize quite quickly. That can take, usually, ideally, we wait anywhere from 10 to 12 weeks. The minimum amount of time that I will repeat a TSH after making an adjustment in thyroid is 6 weeks.
Okay. I have Graves' disease and have had it since 2003, but over the past year, my voice has gotten hoarse and doesn't seem to be getting better. I'm on levothyroxine. I'm probably saying that wrong again. Is it possible for that to happen because of the Graves' disease?
Dr. Shah, no, the Graves' disease is not going to cause hoarseness.
Yeah, and if your Graves' disease was treated with, I presume, because if it's been there since 2003, it was probably treated with radioactive iodine. Since you're on levothyroxine now, it's a burnt out gland. So no, that should not be causing your hoarseness of voice.
Okay, thank you. If your thyroid and parathyroid glands have been removed, will the patient have future difficulties? I think you kind of addressed this previously, right, Dr. Levy?
Yeah.
Yeah, it sounds like it's possible, right? If
Yeah.
some of it's still in there, right? Okay. How do I find a good endocrinologist? I would suggest henryford.com, but
I can vouch for all 9 of us here at Henry Ford. Henry Ford is very selective, and I really like all of my colleagues. They're just wonderful. I would send my family to any one of them.
I agree 100% since I work with them very closely, 100%.
All right, thank you. Is Hashimoto thyroidism associated with alopecia? If so, what can be done about that?
Very good. So the answer, the question that this individual is asking is if I have one autoimmune disease, can I get another? And the answer is yes. Once you have developed one autoimmune disease, you can develop other autoimmune diseases. So, I mean, for alopecia, many often dermatology is the person who you see. For Hashimoto's, you would see a thyroid, but yes, there is a correlation amongst autoimmune diseases.
Okay. And I think you've probably touched on this in some capacity, but what are the side effects long-term of not having your thyroid gland?
Really, if treated properly and monitored, the life expectancy and the quality of life is excellent. It's the same as any other individual. It's only if we're having difficulty getting labs to goal, or there is post-surgical or like some kind of complication that occurred. But most folks do excellent.
All right, thank you. Got that one answered. Why are nodules formed around the glands in the first place?
You know, those are very good questions. I kind of tell my patients this. Past the age of 50, thyroid nodules are very common. And it's kind of like moles on the skin. Why do we get moles on the skin? Because we age. The older you get, the more moles you're going to get. You're going to have to see the dermatologist and be screened. But it's interesting that a bunch of the nodules that I am seeing and that my colleagues are seeing are all incidental nodules. These are not nodules like back in the day, the doctor felt your neck and sent it to you. These are nodules. I had a CT on my head after a motor vehicle accident, and I have a nodule. They're kind of incidental. 95% of all thyroid nodules are benign, very common past the age of 50.
This next one here, I think, kind of goes back to what you were saying, Dr. Levy, about their individuals' PCP kind of being a good advocate. But it says, should people who have low thyroid tests see an endocrinologist, or can a general physician prescribe? So
Absolutely. You know, a general physician is well trained, an internist is well trained. Only when the internist or family practitioner is uncomfortable with, let's say, things are not going in the right direction, will they refer you out to an endocrinologist.
Okay. Why is T3 and T4 not checked as part of the routine physical labs and only TSH is checked?
That's very good. And the answer is because the TSH is the most sensitive test we have. So there are assay issues with the free hormones that we often can see, not to mention that it can be interfered by all kinds of things. Birth control can affect total T4, total T3, pregnancy affects it. TSH is very reliable and probably the most sensitive test for thyroid that we have.
All right, thank you. What is the recommended length of time between taking thyroid medication and then consuming food and liquids like coffee?
Very good question. So traditionally, thyroid pill is a very tricky pill to absorb. You take it first thing in the morning on an empty stomach with a full 8-ounce glass of water. We recommend that we wait 4 hours for any vitamins, specifically calcium, iron. Cholesterol pills and should be taken at the end of the day. Vitamins 4 hours later. To eat or drink, we tell our patients to wait a minimum of 30, but if possible, 60 minutes.
Okay. Is there any truth to damage of thyroid from using over-the-counter cough medicine?
I have not heard of cough medicine leading to damage of the thyroid.
Okay. Is there any difference in Synthroid versus generic levothyroxine?
So we kind of talked about that. I don't have a preference. Synthroid may not be cost effective because it is a name brand. We individualize medication based on what the individual's goals are and what some folks are willing to pay what the insurance companies are not for name brand medications. And some folks, it's just cost prohibitive. So we tailor the care to what we can do best for the patient, but I don't have a particular answer to that. I work with each individual to figure it out.
All right. With hypothyroidism, are there any foods that we should stay away from? Why does it seem hard to lose weight when being active, like walking and working out?
So the answer is there's no particular food. It's just the absorption of how to take the pill can be affected. I know they talked about there is like this concept of goitrous foods, etc., which really doesn't pan out. They talk about iodine containing food or not. I'll tell you this: if you have a toxic nodular goiter, those nodules that we talked about, and you're eating a lot of kelp, which is loaded in iodine, you may flare up and get an overactive thyroid. But in general, if you have a healthy thyroid, you can eat whatever you want. If you have an underactive thyroid, you can eat whatever you want. It's not going to particularly affect you.
Okay. How long, how long on taking levothyroxine before it affects bones becoming more brittle?
Oh, okay. So levothyroxine in general is not going to cause brittle bones. Taking too much thyroid hormone for long periods of time can affect the bones. And we don't know exactly how long, but we know this. We know that anything that leads to overactivity or hyperthyroidism has the detrimental effect of rapid bone loss. So what we want to do is once a year, check the thyroid levels and make sure that they're within the normal reference range. If they're within the normal reference range, they're not causing any ill effect to the bone.
Okay, thank you. How common is it where the patient with hypothyroidism can't tolerate the medicine to correct the high TSH? It looks like they put 8.0 here, and low T3 and T4. Increased replacement therapy causes symptoms of hyperthyroid, like being nervous and jittery.
So we get that once in a while. I have patients who do not feel well on thyroid hormone replacement, and when we try to increase the dose to normalize the thyroid, it is very uncomfortable for them. That is, we get to goal, but they feel awful despite the fact that the labs look normal. And you know what? These are things where we work with the individual one-on-one, so I cannot generalize.
Let's see here. I've been on porcine, am I saying that right? P-O-R-C-I-N-E, porcine, 60 milligrams for about 30 years. In early December, I agreed to go off all thyroid to check what my levels are without. How long before I can have an accurate blood test? 1 month, 2 months? What are your thoughts?
A minimum of 6 weeks.
Okay. How much of an impact does Hashimoto thyroid problems have on rising cholesterol?
So what it is that you need thyroid hormone. We said there's receptors everywhere for the thyroid. The one we always talk about is the heart, but there's receptors everywhere. And when we're talking about cholesterol, you need thyroid hormone as part of the receptor to grab the bad cholesterol called LDL out of the body. So if you don't have sufficient amount of thyroid hormone circulating, you clearly don't have enough for the receptor. So that's how cholesterol goes up. So you need to have normal thyroid function. Often when we see people for high cholesterol, we check their thyroid first to make sure that their thyroid is within normal limits. If their thyroid is underactive, we would treat that first to see if it normalizes the cholesterol. And only if their cholesterol is persistently high would we treat the cholesterol itself.
Okay. You talked about taking the same medication. I have tried to do that, but multiple pharmacies have said they have no control of that. They get whatever is sent in. I cannot request a manufacturer. I'm also unable to request a name brand, only generic. Any suggestions on next step?
So right, and that's true. The pharmacy it's out of their control as far as the pharmacist, but many of my patients will shop around and call. And for instance, I gave the example, not that I have any stock in it, like Mylan brand levothyroxine. Maybe Costco has it, but like Walgreens will not. And many of my patients who want the exact same generic formulation do a lot of footwork in order to get their drug.
All right, moving on here. Do you need a referral to see an endocrinologist at Henry Ford?
Yes.
Yep. Okay, got that. Does Hashimoto's need the TSH level to stay between 1 and 2? I was told this years ago by an endocrinologist at Henry Ford.
Right. So it depends on the goals of the individual. For women of reproductive age, definitely less than 2.5. For our 80-year-olds, I can let it go like a previous question, 7 to 8. So it's got to be individualized. Who I'm talking to, do they have heart disease? Do they have AFib? And then we individualize goals.
All right. This one might kind of go back to what you were talking about with brands. I mean, it says about generic thyroid meds. Say I'm getting Mylan brand now. Should I be checking to make sure my next refill is Mylan? What if it's not?
I mean, the truth is, if you want consistency like the name brands are, without paying for the name brands, the answer is you would have to check that it's a Mylan brand, because otherwise you're getting a generic, which is good, but it's a different generic formulation. And if you've noticed that you're very sensitive to the changes, you would have to be consistently on the same one.
All right. An earlier question about still having symptoms with Graves after having an ablation, the response was to look for other reasons why the hair loss, weight gain, etc. continues. My question is, what other response should be looked for? What am I asking my doctor to look for?
So this is an individual who got radioactive iodine, has normal thyroid labs, and is still having symptoms?
I believe so, from an earlier question.
So, I mean, your doctor would start with just a regular workup. It depends on what your symptoms are, right? If you have global hair shedding, if you're having anxiety, nervousness, tachycardia, they might look for, do an EKG and look for the rhythm, what kind of rhythm you're having. So the symptoms will trigger the workup, what workup is appropriate.
Okay. I think we're right about here at time. Looks like we've got through the questions. Any other final questions before we get logged off here?
Well, I just want to thank everyone. What a wonderful questions. What a wonderful audience. And I want to thank Dr. Shah, and I wanted to thank you, Jeff. This has been such a nice thing that we do for the community, and we really enjoy it. And we're looking forward to it next year, hopefully in person.
Absolutely.
Thank you, Dr. Levy. I echo those thoughts, and I appreciate the opportunity to do this.
Thank you both. With that, I'm going to go ahead and wrap up, and we will get this video posted to our YouTube. And everybody who received the initial invite to this program should receive an email probably this coming week with a link to the video. So thank you all.
Thank you so much. Have a great weekend.
You too.